Okay, last lecture, and it's only going to be like an hour and a half before our exam. The second half of today's lecture, we're going to talk about things to expect on next week's lecture exam. Okay, so the joint's going to be relatively short compared to other chapters that we've done so far. Let me just make sure, because if I know myself, I'm paranoid, and we are recording. Wonderful. Is connecting two parts of the body, typically bones. Okay. So it's connecting two parts of the body, holding them together in an articulation. We're going to use that word. Some books will call joints articulations. That means, what is it attached to? Two bones come together to make an articulation. In some case, three bones to make an articulation. We're going to talk about that today. When we think about bones and how they're joined in joints, they can occur in a few ways. Here, your shoulder joint. Think about your shoulder joint. Think about the things that it's made of. There are ligaments. There are, believe it or not, fluid-filled sacs which lubricate your joint. So you have to think about, what is it made of? And the other thing you have to think about when it comes time to classifying joints, how does it move? These are the two things we need to start thinking about for every single joint. The shoulder joint, it moves a lot. Think about your shoulder, it has a wide variety of locomotion across that joint. You have some joints that move very little, like your pubic symphysis. Very little. And that's pretty much like if you fall, it moves a little bit just to help, like, take in that pressure, that force of the fall. It moves just a little bit so it doesn't snap. There are some joints that don't move at all. So we have to start thinking about, what are they made of? How do they move? These are the two most important questions that you need to ask yourself when you're thinking about how to classify a joint. Functional classification. Functional. How does it move? That's what functional means. That joint between two bones, does it move? For example, we've talked about these. These are the joints that connect your skull bones. These are sutures. How do they move? Do they move a lot? Do those two bones move a lot between that joint? Yes or no, folks? No. This joint is not designed to allow those bones to move. This joint fuses those bones so they do not move. If they are fused joints, they do not move. No motion between joints, between the bones, between the joint. No movement. This is syn. Syn means fused. Arthrosis means joint. Synarthrosis is the functional classifications of joints where the bones are acting like they're fused. There's no movement. in synarthrosis joints? No movement. Amphi. Amphi is a unique word. Amphi means both. Like an amphibian lives on water and land. It lives on both. Amphi, meaning both, this literally means both joints. Well, this is confusing. What this means is it moves very little motion, but it's designed not to move. It moves only if it has to. Like here, this joint right here, between your tibia and your fibula. This is one of your bones that supports the ankles. You don't want these two to move when you're supporting the ankle. So that joint is going to keep them very tightly bound, and it's only going to move a little bit when like you take a stumble, when you take a fall, when you twist your ankle more than you should. It's going to move a little bit to accommodate those motions, but it wants them to stay together. This is an amphiarthrosis joint. Little movement. Diarthrosis. Di means that it moves at least on along two sides, so it has one axis. Diarthrosis means it moves a lot. It's a joint that's designed to move a lot. Like this one. This one's your elbow joint. Your elbow joint can only move along one real axis. It can only move, that's it. Or your shoulder joint can move like this. It can move like this. It can rotate. You can do all sorts of different motions with your shoulder. These joints are the ones that are designed to move a lot. Okay. Folks, these are your three functional class. What you should be asking is how does it move? That is what functional means. There is a classic trade-off. Classic trade-off. If your joints, like the sutures here, they do not move, no movement. That means they have very little mobility. They have a little mobility. They are very stable. Makes sense. You're keeping those bones fused. That joint is stable. Then you get to the ones that have some movement. Like the elbow has a lot of movement, really. So that one has a lot of mobility, lower stability. One of the ones that is the least stable is the one that moves the most. One of your joints that moves the most is your shoulder joint. Your shoulder joint is going to be prone to injury. Why? Because it's very unstable. Makes sense when you think about what joints your patients are going to have issues with. It's going to be the shoulder, it's going to be the hip, the knee, the ankle, the wrist, the neck. Those that are meant to move a lot, they're unstable, and over time, we're prone to injure those joints. Classic trade-off. This is all based on functional classification. Remember, how much does it move? Because that is different Then structural classification. Structural classification, what you need to think about is what is it made of? What is the joint made of? That's what's going to define what its structural classification is. So every joint has two types of classification. For example, back to our suture joint. How does it move? No movement. What is the functional classification when it's no movement? Syn, arthrosis. The elbow, a lot of movement. What is the functional classification? Diarthrosis. We haven't talked about it yet. But structural classification, what is it made of? What are these fibers that hold the sutures in place? Okay. They are collagen fibers. Okay. They are collagen fibers. What are the elbow joints made of? They're made of these fluid-filled sacs. If it's made of collagen, we call that a fibrous joint. Fibrous, because it's made of collagen fibers. That is the structural classification. If it moves a lot, odds are it's going to have those fluid-filled sacs. We're going to talk about these. Those fluid-filled sacs are called synovial. Synovial sacs, synovial membranes. So the elbow is a diarthrosis functional class and synovial structural class. The suture is a synarthrosis functional class and a fibrous structural class. Every joint has two classifications. How much does it move? What it's made of. On your cards, please. The knee, when it comes to the functional class, what are you going to tell me it is? Diarthrosis. The knee moves a lot. What did you give a stab at? What the structural type? What do you think it's made of? It is made of a lot of synovial sacs. Most diarthrosis joints will also be synovial. This is going to be our main focus on this lecture. Why the knee is going to be one of the ones we mess up the most. How many of you guys have had knee issues with your joints? Torn ligaments, torn menisci, torn bursae. All right. As we grow older, more hands are going to go up. It's just a natural part of life. Structural classifications. Here's our first one. Fibrous means it's made of collagen fibers. That joint is made of collagen fibers. A suture is a great example. Those are made of collagen fibers. This is a fibrous joint. Keep in mind, this one is no movement. So this one is synarthrosis. Here's its structural. Here's its functional. This one is weird. Look at this one. This joint is made of a long collagen ligaments. So it's made of collagen. But that one is designed to have a little bit of movement. It is not synarthrosis, folks. This one is their amphiarthrosis. So fibrous joints can be both. Fibrous joints, they're made of collagen, can be both synarthrosis functional type or amphiarthrosis functional type. This is just describing what it's made of. One of my favorite ones, because of the name, is gomphosis, because those are the ones where your teeth are attached to your maxillae, to your mandible. They're made of short collagen fibers. They're not designed to move very much. No movement. Synarthrosis. Synarthrosis. Okay, so for structural classifications, I only want you to tell me if it's a fibrous joint. You do not need to tell me the specific types of fibrous joints. So you don't have to tell me if it's a gomphosis, you don't have to tell me if it's a suture, you don't have to tell me if it's a syndesmosis joint. There are even those types of breakdown. We're not going to go that far. Structural and functional type only. The second one, the second type of structure, cartilaginous joints. These joints are made of cartilage connective tissue. Well, which one? That's what's going to determine the different types of joints that can occur. Like this one, the one that attaches your first rib to your sternum. This is made of hyaline cartilage. If the joint is made of hyaline cartilage, most of the time, it's going to be synarthrosis. You do not want that joint to move. If the joint is made of fibrocartilage, connective tissue, fibrocartilage, it's going to have a little movement. Fibrocartilage joints tend to be amphiarthrosis. Okay. So cartilaginous joints are either going to be made of hyaline cartilage or fibrocartilage, and they tend to fall under those two functional classes, depending on which cartilage they are made. Functional versus structural classification. Our last structural classification are synovial joints. Synovial is a fluid that literally acts as a lubricant. Your body produces synovial fluid in between the joints, so they act as a lubricant. Do you see that black space between this knee joint? That is all filled with synovial fluids inside there. So there's a little thin membrane that holds the synovial fluids inside. So that is a synovial sac. A synovial, oh my goodness, let's try that again. Synovial sac that has synovial fluid held inside. That is the lubricant for this knee. Okay. There will be other things that help lubricate, cushion the joints. This is what defines synovial, okay? Some synovial joints, not all, will have bursae. These things that are green. There's one there, there's one there, there's one there, there's one in the back, there's a little one back here. These are bursae. These are filled with bursal fluids. These act kind of like a lubricant, but they are more to provide a cushion, and it's typically for the ligaments that are within them or between bone on bone. So bursae will also be important for the joints, especially in the knee. The other thing that your knee has, it's always fascinating when we look at the knee, is it's going to have designated fat pads. And those fat pads are not for energy support, energy storage. Their sole purpose is to cushion the joint. So you have both fat pads and bursae that will also help provide additional cushioning, structural support for a joint. Joints will have ligaments. There's a ligament back here. Ligaments are where bone hold on to bone. If it's a bone to bone attachment, it is a ligament. It holds the bones together. It prevents them from slipping when there's movement. That is different than a tendon. What does a tendon hold? It holds bone to what? It holds bone to muscle. I need you to know the difference between those two. They're both made of the same materials. They're both made of collagen fibers. It's just what is holding on to what that is different. Okay. On an exam, I expect you to know what a ligament does. Ligament holds bone to bone for support when the bone moves, when the joint moves, wants to keep things in place. The tendon powers the movement. It provides the energy that powers the movement, but don't forget, it also supports the bones. Think about having to stand up straight. It keeps your bones standing up straight. The muscles do. Those that attach, muscles attached to bone via tendon to keep things supported. The synovial fluid is the lubricant. The bursae and fat provided cushioning. Be able to tell me what these structures do for a synovial joint. Here's the example in the knee. Synovial joints are further broken down to how they move. We're going to keep it simple. We're going to keep it on the type of axes that they move in. So we're going to look at 3 different axes. Check this out. Number 1, your elbow joint. Your elbow joint is only designed to move along one axis. It just moves on that axis and that axis alone. Moves that way, you extend it and flex it. That's all you can do across the joint. Extend and flex along one axis. This is called a monoaxial synovial joint. One axis, it can only go this way or this way. That is it. The elbow is a monoaxial, but is also a hinge joint because it acts on a hinge. That is the example of the elbow. The elbow is a monoaxial joint. It is a synovial joint. It is a hinge joint. Those all apply to how the elbow works. The knee is a weird one, but yes, it's primarily going to function as a hinge. The reason that makes the knee weird is the patella. We're going to talk about that. We don't even classify it because of how challenging it is. Okay, so these are the only 3 examples that I'm going to ask you on the exam, by the way. Okay, since we only have 1 week before it. This next joint moves along 2 axes. Okay, this one's your thumb, by the way. Your thumb does this weird thing where it'll move in this direction. So you can do thumbs up, thumbs down, but it'll also allow you to move it in this direction. So it has 2 axes. This one is a bi for 2 axial joint. And the thumb is specifically a saddle joint. Okay, because of how it moves along those axes. The thumb kind of sits down on this saddle, which allows it to move not on one axis, but 2 axes. That's why it's called the saddle. 2 axes, biaxial. The one that gets really, really challenging is things like the shoulder and hip. The shoulder, as shown here, moves along almost 4 axes, but because it's a ball and socket, it's technically 3. This is considered 1 axis because it's a ball. So this is when you like move it this way or move it this way. Look at how my hand is staying in the same position. That is 1 axis. Here's another one. You can rotate it. That is circumdection. This one. And then the weird one is I can keep my elbow, my shoulder in position, and you can rotate. You rotate it as well. So that is that 3rd one here. So one is circumduction, where it's pivoting you're pivoting here, rotation, and just forward adduction, forward flexion. We'll talk about those at the end of lecture today. Because this one has 3, this one is a triaxial joint. And the elbow is a classic ball and socket joint. All of these are synovial. All of these have synovial fluids. Not all of these have bursae. So that's why it's classified as synovial joints, because they all have the synovial fluids for lubrication. By the way, when you do this, what do you think you're popping? Your synovial fluid. That is the sound of it leaving the joint. It'll return, but that popping is the sound of those fluids leaving because of the pressure you put on it. It's the same thing. It's the synovial fluids leaving. Yep, the ankle itself. Okay, and I'm not the tibia and fibula. Okay, good. I did this already. I forgot that I had a separate slide for this. I apologize. So let us review. What is the black space filled with? And what do those do for the joint? Lubrication. What about here? We have bone to bone, ligament. And ligaments provide what for the joint? Support. Here, bone to muscle, tendon. What does that do? Power the movement and support. What are the green things? Bursae, bursa. And I heard it, they provide what? Cushion. What is all this yellow stuff? Fat pads. And what does it provide? Cushion. Right, these are the main elements that I want you to be able to tell me in the knee joint, how they help the knee deal with stress. There's one more that I completely forgot, and I'm glad we're doing this. It's not shown here. Not shown here, so let's draw it in. Oops, cancel. Let us draw it in. You have a very specialized pad in here. And it sits right there. Does anybody know what that pad is? It's the disc. What is it? You have 2 of them. It's made of fibrocartilage. Good. Your knee meniscus. You have 2 of them. You have 2 of them at the knee. And they are super important. Why? All your weight comes bearing down on that pad. The knee meniscus is designed to resist compression, so you don't grind your femur to your tibia. That is painful. That is painful. Many of you probably know people whose meniscus is gone and now their femur grinds on the tibia because the meniscus is gone. That is excruciating. cannot be fixed. If they can, that's a bit, not always. Not always. Depends on your age, if you've already had one, and what caused it. Why is it so easy to tear? Well, it's the way that it's attached. And who usually tears it, especially at your guys' age? When do you guys usually tear it? In high school, playing what? Playing sports. Guess what? Your knees are not supposed to move like that most of the time. When you're doing the jukes, when you're dribbling the soccer ball, right? Your knees are not designed to really move like that. So there's a lot of wear and tear on the meniscus. Okay, the meniscus is usually one that gets torn. It is not fun. The knee ligaments. How many of you guys, anyone here ever have an issue with the ACL, PCL, MCL, LCL? We need to know what those words mean. You're going to hear it all the time. Oh, so and so tore their ACL. Happens all the time at the knee. And I'm going to label it on the exam, and I expect you to be able to ID it. Okay. I'm going to give you a knee image just like this. And I'm not going to even tell you if it's the right or the left knee. You have to tell me. I can tell you that's the right knee. How do I know? Because of the way that the bones are arranged. I need you to understand how these bones are arranged. Up top, this is the femur. This is the bone that is in your thigh. This one is the tibia. This is the bone that makes your leg. The little tiny one, which one's the little tiny one? And guess what? Your fibula is always, that's how I know that's the right knee. Always on the lateral side. Your fibula will be the landmark you need to use to visualize which ligament are we talking about, because I'm going to ask you to name that ligament in purple. Look, it's attaching the fibula to the femur. What side is it on? Is it on the medial or lateral side? Guess what that one's called? Lateral LCL. Don't call it LCL. Close. Lateral collateral ligament. LCL, lateral collateral ligament. So what is the name of this one in blue? MCL. What does the M stand for? Medial collateral ligament. MCL. Collateral means that they're just on opposite sides. Because I think lateral collateral ligament sounds redundant. It really does. Okay. But since they're on both sides, it's describing the lateral one. That's all. Now there's the ACL and PCL. What do you think the A stands for? And the P? Posterior. Okay. All right. So this is where your patella would sit. And I know this because this is the patellar ligament. So the patella has been removed so we can see inside of the knee. The patella's been pulled out. This one that goes out here and it goes into the front of the tibia. That attaches to the front of the tibia. Here's the top view. Here's the anterior side. If it attaches to the front of the tibia, that one is your ACL. It is your anterior cruciate ligament. It's not a collateral ligament. It's a cruciate. Think of it as a crucial ligament in the thigh. I didn't make these names up. I'm sorry. There's one in the back here. That one is the one that attaches to the back of, come on, the posterior side of the tibia. Those two in the light and dark green are your posterior cruciate ligament. Now we know what ACL, PCL, MCL, LCL means, how they're named, where they're located. Don't forget, hold on, let me see what color schemes I used. I haven't used pink yet. Don't forget to tell me what's in here. What's that pad called? Meniscus. You have two of them. Here they are. Meniscus means half moon. They look like half moons. This one on this side is on the medial side. Medial meniscus. What do we call this one? Lateral meniscus. I wouldn't label them up here. Why? Where's the fibula? Can't see it. I would label it on something where you can clearly see the fibula. So you can tell me which one's the lateral, which one's the medial. Those are the knee joint ligaments, meniscus. Told you we're going to cover the knee like crazy. These are structures that are likely to get injured in a sports-related, age-related, fall-related injury. So the knee is designed for compression resistance, ligaments, etc. Okay. What ligament is this one? Lateral collateral ligament. This one. Medial collateral ligament. This one. Anterior cruciate ligament. What is this structure called? What are you going to call this one in blue? Lateral meniscus. Are we ready for this? What type of structure is this? Is this a tendon or a ligament? Ligament, bone to bone. This one connects the patella to the tibia. That is your patellar ligament. Bone to bone. This one's tough. This one above the patella. Those are all the same structure. They're just three parts. That is a tendon. Why is it a tendon? And it is your quadriceps tendon. Quadriceps, sorry. I had to think about that one. It connects your patella to your quads. Your patella essentially acts like a pulley, and it allows you to have more movement across that joint. Your muscles, your quads are actually attached to the patella. They're not attached to the leg. The patella is then attached to the leg. So the quadriceps are indirectly attached to your leg. The patella is literally just acting like a pulley mechanism there, which helps increase range and rate of motion. How much it moves, how fast it moves. That's what a pulley does. It increases the range and the rate of motion. Why? Because of the rest of the parts have to help support the body mass. That's why we only have meniscus in the knees. We don't have it in the elbows. We don't have it in the shoulders. They have to be designed to compress and resist body mass. What are you gonna tell me for 3? Cushion. 4. Resist compression, compression resistance. Body motions. We have to describe, and we're gonna have to get used to this. We're gonna have to describe motions of the body across our joints. This is part of our joint lecture. Probably gonna have a lot of you guys stand up for this. You might as well stand up now. Let's stand up. Let's wake up. Give yourself some distance from your neighbor. I don't want you whacking them. Angular motions. Don't put the arm out. Flexion. Extension. Pay attention to what's happening here. The angle is getting smaller. Flexion. Extension. Look at what's happening when you bow. The angle gets smaller. Flexion. When you do a sit-up, when you stand up, extension. Flexion, extension. Okay, the one that's weird is the arm. Look at the arm. Flexion. Sorry, extension. Brain fart. Flexion. One more time because I said it wrong. Extension. The angle's getting bigger. Flexion. The angle's getting smaller. Listen to this. Show me flexion of your forearm. Someone's going to say, this is flexion of the arm. Wrong. Flexion, wrong way. Flexion of the arm. Flexion of the forearm. You have to be able to use the terms appropriately. Flexion of this part. Extension of this part. So you have to know the parts. Where it gets really crazy is flexion of the thigh. The angle is getting smaller. Extension is putting it this way because the angle gets bigger here. And then, to make it tricky, flexion of the leg. Leg. There is no lower legs. Extension of the leg because the angle is getting smaller. Flexion, bigger. extension. You're going to have to use them to describe what's happening in your patient. Because you're going to have a patient say, it hurts when I do this. That's all I'm going to tell you. And you're going to have to use the right terminology. It hurts when they flex their arm. That's why these are angular movements. It's all about, is the angle getting bigger or smaller? There's flexion extension again. These ones are my favorite. We're not done. Well, we're not done. We have a few to get through. Abduction. Adduction. I didn't make this up. One letter off. Abduction. Let me show you. Go from here. Abduction. It's closer to the body. I said it wrong. Adduction, getting closer to the body. Abduction, going away from the body. You ready for this? See if I can do this. It's been a long day. Abduction of the thigh. I'm about to fall over. Adduction. I have to do it fast. Adduction of the thigh, getting closer. What does it mean? Adduction. Remember, adduction, you're bringing it closer to the body. You're adding it to the body. Add means bring it closer to the body. What happens when somebody says, I hope I don't offend anybody, they were abducted? They go away from the planet. Abduction, away from the body. Adduction, you're adding it to the body. Abduction away, adduction closer. Circumduction. Rotating around the ball joint. Circumduction, can I do it with my, it's been a long day. Circumduction. All right, you remember those 90s workout videos? In others. In others. Yeah, I'll ask you what's that movement across. That's the example I will use. You can do circumduction with other very specialized ball and socket joints, but those are the best examples. Did somebody have a hand up? We practicing? Good. Rotation. Rotation. This is just regular rotation. Then, look at my thumb. I'm only going to rotate my humerus. Medial rotation. My thumb went towards the midline. Lateral rotation. My thumb is going away. I'm only rotating this. Same with the thigh. Lateral rotation. Medial rotation. It moves my fingertips either medially, my thumb, either medially or laterally, depending on how I rotate it. This is going to be very important, especially if you go into sports medicine, because rotator cuffs get busted all the time. When someone's pitching that ball, throwing the football, doing the tennis swing, you're going to have to be able to describe, is the muscle a medial rotator of the humerus or a lateral rotator of the humerus? Pronation, supination. This body motion across joints only occurs in the forearm. Okay. When you are in anatomical position, your forearms are in supination, palms facing forward. That means your ulna and radius are parallel. When you're in pronation, they're facing the other way. Believe it or not, your ulna and radius cross when you're in pronation. Supination. Asking for soup. Pronation. Look at my professionally done nails. No, that's how you're gonna remember it. You're gonna be like nails, soup, supination, pronation, nails. Okay. What's that? No, no, just the forearm. Forearm. It's of the forearm. Okay. This one sucks. Both are flexion. Look at that. Plantar flexion, dorsiflexion. You have to remember the sides of the foot. What is the bottom of the foot called? The plantar. So the plantar, when you bend your ankle towards the plantar, that is plantar flexion. That is putting your tippy toes down. Plantar flexion. The top of the foot is called the dorsal surface of the foot. So when you bend it that way towards the dorsal surface, it is dorsiflexion. And then the spelling sucks. Dorsiflexion is one word, plantar flexion is two words. Whoever invented this needs to be taken outside and dealt with. This makes it hard, right? That makes it hard. Plantar flexion, dorsiflexion. Okay. And then dorsi. It's not even dorsal flexion, it's dorsi flexion. Don't do this. How you break ankles. But your body has to do this when you're like doing hikes, when you're on uneven ground. Inversion. That means you're making your feet do this. Ouchies. Like that. Look at. That's how you're gonna break your ankle if you walk around like that. Worse is eversion. I can't even. That's as far as I can go. Inversion and eversion. Right? People who practice sports, like this person, train their bodies to do it to an extreme. That's why people in sports medicine get injured. Because they train too fast. And eversion is laterally. Elevation. Close the jaw. Up. Depression. Open the jaw down. You can do this with the shoulders. The teenager. Elevation. Oh. Depression. Shoulders down. Sliding things up and sliding things down. Elevation, depression. I'm going to ask you some of these on the exam. What motion is this? What motion is this? All right, you're going to have to be able to tell me. Why? When we get to muscles in lab, it's going to help knowing what those muscles do. To be able to identify. Some muscles are named after what they do. For example, the flexor carpi radialis. It flexes the carpi region. Where's your carpi region? Your carpal. So you have muscles that flex the carpal. So knowing how they're named because of how they move things. One of my favorites, because it sounds like a Harry Potter spell, is levator scapulae. It elevates the scapula, the teenager. We're gonna have to be able to name those muscles. Take a 10-minute break. Come back at 55, and we will continue this series. I'm gonna stop it.